Good morning, everyone. I hope you are enjoying the meeting and also this wonderful island. This presentation will be about four main topics. The first one, countries of the region that have introduced the rotavirus and pneumococcal vaccine. The second one will be about epidemiological surveillance of rotavirus and bacterial pneumonia and meningitis. Special studies and evaluations and conclusions and recommendations. This map shows all the countries that have introduced the rotavirus and pneumococcal vaccines in their national immunization schedule to date. Cayman Island have introduced both of vaccines, rotavirus and pneumococcal vaccine. There are currently 16 countries that have introduced the rotavirus vaccine in one territory, 13 countries that have introduced the pneumococcal vaccine in 4 territories. In the case of rotavirus vaccine, I would like to mention that it's the first time that countries in developing countries have introduced a new vaccine at the same time as a developed country. This table shows us the number of countries that have implemented surveillance and are reporting to Pan American Health Organization. Last year, in 2009, 16 countries conducted rotavirus sentinel surveillance and 10 countries meningitis and pneumonia sentinel surveillance. This is a table of the rotavirus sentinel surveillance that received from countries that reported in 2009. I'm going to focus in the next 4 slides in rotavirus surveillance because the data are more systematic and with better quality than invasive bacterial disease surveillance. You will notice that most of the countries that have introduced the rotavirus vaccine 2 years ago, like Ecuador, El Salvador, Nicaragua, Panama, and Venezuela, have a decrease in the percentage of positive rotavirus cases, less than 26% of positive cases. Actually, we do not have an explanation for Chile and Suriname, who still has not introduced the rotavirus vaccine, but has a low percentage of rotavirus cases. The estimates of number of deaths due to rotavirus diarrhea for the years 2006 and 2007 was taken from PAHO surveillance data and was recently published in the Journal of Infectious Disease in November 2009. We can see that the risk of death due to rotavirus diarrhea among children under 5 was highest in low-income countries such as Bolivia, Guyana, and Guatemala. And that overall in the 10 countries analyzed, 3,492 children die annually of rotavirus disease. This is equivalent to a mortality risk of 1 in 208,074 children. PAHO results were very similar to WHO estimates of 3,416 deaths annually and a total risk of 1 death in 2,937 children less than 5 years in these countries. Seasonality and rotavirus infection are important to take in consideration. This graph shows us that in 2006 and 2007, the rotavirus season peaked from November through March in the North Hemisphere countries, and the reverse seasonality was evident in the countries in the Southern Hemisphere from May through September. The most marked seasonality was observed in countries north of the equator, with rotavirus season peaking in February and March, and you can see it in the figure A. This graph shows us an updated version of rotavirus infections and seasonality in 5 Central American countries from 2007 to 2009. You can also notice that each year rotavirus infection peaked from November through March. PAHO is conducting various studies in different countries of the region. These studies are collaboration among CDC and Ministries of Health and sometimes with other organizations. I'm going to show you some of the studies that we are going to working on with the countries. Study on security of the rotavirus vaccine. This study was conducted in Brazil and Mexico, and this study is ready, and it will be published in a few weeks. The other study that we have conducted was the study on effectiveness of the rotavirus vaccine, and we conducted this study in Nicaragua and El Salvador, which are ready and published in last year, and now we are working on the Bolivia effectiveness study. Now I'm going to present some results from Nicaragua and El Salvador effectiveness studies. The Nicaragua study showed an effectiveness of 46% for children admitted to the hospital with a confidence interval between 18 and 64%. The effectiveness for children with severe diarrhea was 58%, with a confidence interval between 30% and 74%. And the effectiveness results for children with very severe diarrhea was 77%, with a confidence interval between 39 and 92%. The effectiveness study in El Salvador showed an effectiveness with 2 doses against hospitalized diarrheas of 76%, and the confidence interval was between 64% and 84%. The effectiveness for children up 12 months was 59%, with a confidence interval between 27 and 77%. And finally, the effectiveness in children between 6 and 12 months was 83%, with a confidence interval between 68 and 91%. We are working on a study on the effectiveness of pneumococcal conjugate decavalent vaccine in Brazil, which we just has started. We are working on the documentation of the introduction of new vaccines in Bolivia, Brazil, Nicaragua, Peru, and Venezuela. Also, we are working with trends study of diarrhea hospitalized and death in children under 5 years old in 5 countries: Bolivia, El Salvador, Honduras, Colombia, and Venezuela. Also, we have some evaluations that you have worked in the countries. A pilot evaluation of the surveillance system of bacterial pneumonia and meningitis was conducted in Guatemala in 2009. The post-introduction evaluation of new vaccines, in this case, rotavirus vaccine in Ecuador, which took place in September 2009. An international EPI evaluation in Bolivia took place in August 2010, and the Nicaragua evaluation took place in October 2010. Now I would like to share with you some conclusions and recommendations. The introduction of the rotavirus and conjugate pneumococcal vaccines are happening at an accelerated pace in the region of the Americas. There is an increased knowledge regarding rotavirus effectiveness, security, and impact. Sentinel surveillance in country is critical for effectiveness studies and to assess the impact through other methods. Implementation of epidemiological surveillance of new vaccines, preventable disease, could help to monitor prevalence of circulating strains and changes in epidemiological profile. For countries that have already implemented the vaccines surveillance, it's crucial to improve the quality of the information and also to report systematically this information to Pan American Health Organization. And finally, I'd like to tell you that in our experience with the introduction of new vaccines in the region, It's fundamental that universal introduction of new vaccines, because this universal introduction of new vaccines will allow impact evaluation, reliable vaccination coverage, and equity with regards to vaccination access. The implementation of vaccination schedules must be evidence-based and therefore recommended by the Technical Advisory Group and WHO SAGE Group. I would like to say thank you for your attention, and I hope this information are useful for you.